Friends, now we'll see various other aspects of head injury. In this session, we'll cover other types of head injury, their management and their rehabilitation. Now we'll begin with acute subdural hematomas. So acute subdural hematomas, it is the accumulation of blood in the space between dura and arachnoid. So we have seen extradural hematomas. Now we'll see hematomas occurring below dural membrane in between dura and arachnoid. It is called as subdural hematoma. They can be acute in type. So etiology is mostly disruption of cortical vessels or by brain laceration. So whenever there is laceration of cortical vessel, they produce subdural hematomas. Acute subdural hematoma is nearly always associated with significant primary brain injury. So many times you will get these subdural hematomas. They may be associated with underlying brain contusion or underlying diffuse axonal injury. So there may be shift of brain parenchyma to other side with massive increase in intracranial pressure. Many times it is associated with uncal herniation and immediate its effects. So patients will present with impaired level of consciousness from the time of injury, but further deterioration can occur as the hematoma expands. So as compared to in extradural hematoma, what we have seen earlier, lucid interval is absent in subdural hematomas. So lucid interval is characteristic of extradural hematoma. It won't be present in subdural hematomas. So patient will be unconscious from the beginning. What are the investigations? The CT scan of acute subdural hematoma will show hyperdense. So whenever there is accumulation of blood, which is acute event, the blood will appear as hyperdense. So hematoma will spread across the surface of brain, giving it rather diffuse and concave appearance. So as you can see in this figure, the hematoma has got concave appearance. So as compared to extradural hematoma, which has biconvex appearance, this subdural hematoma will have concave appearance. Why there is concave appearance? You can see this concavity spreading across the one brain hemisphere. So this occurs because there is less resistance to blood moving through subdural space than through extradural space. So in extradural space, as the dura is firmly attached to calvarium, there is more resistance and it will spread only focally. But in subdural space, because of least resistance, the blood will spread over the hemisphere. What is the treatment? Usually it is evacuated via craniotomy. Small hematomas with little mass effect may be managed conservatively in neurosurgical centers. The mortality rate from acute subdural hematoma is much higher than extradural hematoma. So generally they are evacuated with craniotomy. So now we'll see what is meant by mass effect. So whenever there is diffuse or massive shift of midline brain structures to opposite side, it is called as mass effect. Now we'll see for one more entity, that is subarachnoid hemorrhage. So it is the bleeding over brain parenchyma just below the arachnoid matter. So trauma is the commonest cause of subarachnoid hemorrhage. Aneurysms are next to the cause of subarachnoid hemorrhage. So if you are asked what is the most common cause of subarachnoid hemorrhage, it is the trauma. And if you are asked what is the most common spontaneous cause of subarachnoid hemorrhage, it is the rupture of aneurysm. So aneurysms are the most common cause of spontaneous subarachnoid hemorrhage, and trauma is the commonest cause of subarachnoid hemorrhage. So this is difference should be noted. So there may be fine change in question. You should read it carefully. What is the treatment of choice? So treatment of subarachnoid hemorrhage is managed conservatively. So many times it forms a thin layer over the brain parenchyma. It will resolve on its own when you supplement with mannitol and other ancillary measures like maintaining good oxygenation and blood pressure. From acute subdural hematomas, now we'll see chronic subdural hematomas. So we'll see now what is the main etiological factor. They usually occur in elderly people. So why it is so? It is because as the patient grows, the bony calvarium remains static, but the brain undergoes atrophy. So there is more space between calvarium and brain parenchyma. So whenever there is this more cavity, the small vessels that they breach, they easily rupture and they will form chronic subdural hematomas. So it is also common in those on anticoagulant or on antiplatelet agents. Small bridging veins tear and they will cause small acute subdural hematoma which is clinically silent. As the hematoma breaks down, it will increase in the volume and will cause mass effects on the underlying brain. So initially the hematoma is acute and small in the subdural space, but as the period progresses, this hematoma undergoes breakdown and it will increase in the shape, leading to the mass effect. What are the clinical features? The clinical features are very peculiar. Patient will be conscious all throughout the course, but will complain of headache. Next, there will be cognitive decline. Next, there will be focal neurological deficit. That patient will present with hemiparesis or monoparesis. Or patients may present with seizures. So all these symptoms, they lead to some psychological imbalance. So you should identify these patients very carefully. It is important to exclude hypoxic, metabolic and endocrine disorders in this group of patients. The CT appearance of chronic subdural hematoma is variable. So now we'll see various changes that occur in CT scan with respect to time. So acute blood that is collected in subdural space from 0 to 10 days will appear as hyperdense. So please note these changes. So you may be asked, if the patient presents on this day, what will the CT scans finding? You may be given various options. The CT scan will be hyperdense, isodense, like that. Now we'll see what are the changes that occur in blood on CT scan. So acute blood from 0 to 10 days will appear as hyperdense, whereas subacute blood from 10 days to 2 weeks will be isodense related to the blood. So 10 days to 2 weeks of duration of subdural hematomas will appear as isodense lesion as compared to the brain parenchyma. Whereas chronic blood, so more than 2 weeks of duration, will appear as hypodense. So they will be of lesser intensity as compared to the brain parenchyma. So these changes should be very much important because they may decide the management. So whenever you have got hypodense lesion, so blood is more of a liquid quality and they can be drained via boreholes. Now we have got entity of acute on chronic subdural hematoma. So whenever this entity is encountered, it often has in areas of more recent hemorrhage in more dependent posterior areas. So they may have variegated appearance. So in posterior areas, they have got acute collection of blood. Now we'll see treatment options for chronic subdural hematoma. So chronic subdural hematomas and most acute on chronic subdural hematomas are evacuated via boreholes rather than craniotomy. So if you are asked question, the treatment of choice for drainage for chronic subdural hematomas, you will be given craniotomy, borehole or craniectomy. So it is the borehole that is main treatment of choice. So you can have 2 boreholes. The appearance will be same as acute, but it will be isodense or hypodense. So you can have boreholes created at frontal region and at the temporal or occipital region through which you can drain this hematoma. So this is an important distinction as boreholes can be easily performed under local anesthesia in elderly patient with extensive comorbidity. So as compared to acute subdural hematomas, the chronic subdural hematomas can be managed under local anesthesia. Now we'll move on to one more entity called as cerebral contusions. So we'll see etiology. The cerebral contusions are common in head injury and they result from brain being damaged by impacting against skull either at the point of impact, that is called as coup, or on the other side of the head, that is called as counter coup, or as the brain slides forwards and backwards over reach cranial fossa floors. So whenever there is sudden stoppage of calvarium against a hard object, there occurs the coup injury. So where the point of contact, there is coup injury, and at the opposite to the point of contact, there is counter coup injury. So if this is a traveling brain, it will hit, the coup injury will be produced in frontal region and counter coup injury will be produced on occipital region. So this is against the hard object, but many times you may get counter coup or coup injuries inside the brain parenchyma itself where there is fixed bony ridges. So most often they will affect the inferior frontal lobes and temporal lobes. So this is the most important point. So frontal lobes and temporal lobes are affected most often in cerebral contusions. What are the investigations? Cerebral contusions on CT scan appear as heterogeneous with mixed areas of high and low density. There may be associated mass effect. So whenever there is cerebral contusion, it will cause edema around it. So it will press the brain hemisphere on the opposite side, leading to the mass effect. A contusion may be described as an intracerebral hematoma if the lesion contains large amount of fresh hemorrhage and therefore appears uniformly hyperdense. So you should be able to differentiate between acute hematoma and contusion, because many times a ruptured intracerebral aneurysm or any AV malformation may give rise to the same appearance as contusion. So contusions with more component of blood, they may be as an effect of rupture of AV malformation leading to the intracerebral hematomas. So this fine difference between contusions and cerebral hematomas should be noted. A head injury patient with cerebral contusions must be admitted for observation, as these lesions will tend to mature and expand over 48 to 72 hours following injury. So as the period progresses, the lesions which are appearing small, they may enlarge over a period of time because perifocal edema will increase. A small proportion of cerebral contusions will require delayed surgical evacuation to reduce the mass effect. So whenever you have got mass effect and impending herniation, you should do craniotomy and evacuate the hematoma so as to allow the brain to expand, and you have to take out the dead brain parenchyma so as to reduce the hematoma and edema. Next, now we'll see what is meant by diffuse axonal injury. So diffuse axonal injury, whenever you get patients, they are in generally deep coma. They have Glasgow coma scale of less than 5 to 6. So they are deeply comatose. CT scan will show only cerebral edema in majority of the patient. So patients CT scan will not show mass effect or like that thing. There will be only generalized edema and patient will be deeply unconscious. So in these patients, the treatment is generally conservative. It is prolonged with good nursing care. You will have to support initially with mannitol and IV fluids, and later on you can wean these patients on tracheostomy. Mind well that in these all patients, nutrition is a main key factor, because they cannot be fed on their itself. Nutrition is maintained through rice tube or by feeding gastrostomy. Friends, now we have seen various types of head injuries. Now we will see how to manage them or how intensively they are managed in neurosurgical unit. So intracranial pressure monitoring forms the mainstay of treatment in these head injury patients. So ICP monitoring is useful adjunct in the management of unconscious patient with head injury. A sustained intracranial pressure of more than 20 millimeters of mercury is associated with worse outcome. Intracranial pressure can also be used to calculate cerebral perfusion pressure as seen earlier. Many times decompressive craniectomy may be required for patients who are unable to manage on medical line of treatment. So craniectomy is to control intracranial pressure in patients without a focal intracerebral hematoma in whom intracranial pressure is refractory to maximal medical therapy. The operation involves removing of large section of skull and opening the dura, allowing the swollen brain to expand underneath the skull. So dural opening is very much important as craniectomy. So you have to open the dura, otherwise the brain will not expand. The bone flap is stored in thigh or in anterior abdominal wall below subcutaneous region, and which has to be replaced after 3 to 6 months later when the patient has made good neurological recovery and the brain swelling has resolved. Environment in neurosurgical unit is very much important. So severe head injury is best managed in neurointensive care setting, and mortality is reduced compared with general units even if no neurosurgery is performed. So neurosurgical management, this is very important. The patient should be positioned with head up to 30 degree if spinal clearance aroused. So if patient does not have any spinal injury, patient are given propped up position. It is important to ensure that cervical immobilization collar does not obstruct venous return from the head. Now we'll see airway and ventilation. What are the indications? The patient in traumatic coma is unable to protect their airway and is risk of aspiration. Gas exchange may be impaired if the patient's airway is not maintained. Airway maintenance makes the safe intra-hospital transfer of the patient with an impaired conscious level and who is at risk of further neurological deterioration. En route requires intubation. So patients who are Glasgow's coma scale less than 8 should be intubated and transferred across the hospitals whenever required. So normal gas exchange in head injury patient must be confirmed and maintained. hypoxia and hypercapnia will result in increased brain ischemia and secondary brain injury. So the most causative factors to cause secondary brain injury are hypoxia and hypercapnia. A single episode of hypoxia with PO2 of less than 8 kilopascals is associated with worse outcome in traumatic coma. So this is very important point. So oxygen saturation or oxygen concentration less than 8 kilopascals is associated with worst outcome. Amongst the prevention of hypoxia, normocapnia should also be maintained. So PCO2 levels should be maintained between 4.5 to 5 kilopascals. So cerebral vasculature is reactive to carbon dioxide levels. A rise in partial pressure of carbon dioxide in head injury patient will result in further events as. So once patient has got hypercapnia with increased intracranial pressure, they will have generalized vasodilation. So brain vessels are responsive to carbon dioxide saturation. So whenever there is increased amount of CO2, they will cause vasodilatation. Vasodilatation will increase the blood flow in the brain parenchyma. So once the blood flow increases, they will cause raised intracranial pressure and reduce cerebral perfusion. Conversely, if you hyperventilate this patient, so many times hyperventilation therapy is given for patients who have raised intracranial pressure. So hyperventilation will cause fall in partial pressure of carbon dioxide. It will cause generalized vasoconstriction. That will cause fall in intracerebral blood volume and it will drop the intracranial pressure. So this appears very interesting. So whenever you have got raised intracranial pressure, you can hyperventilate patient. Overall, superficial, prima facie, this looks very interesting fact. But mind friends, whenever there is decrease in intracranial pressure associated vasoconstriction, there will be more injury to ischemic zones. Although this global effect on intracranial pressure may seem beneficial, it occurs at the expense of perfusion of ischemic areas of brain and therefore it will result in higher likelihood of cerebral infarction rather than recovery from ischemia. So whenever you have to reduce cerebral intracranial pressure with hyperventilation, you should do it very cautiously. It is for this reason that hyperventilation to induce hypocapnia is used by anesthetics experienced in care of head injury patients as an emergency measure to temporarily reduce intracranial pressure while definitive care or urgent investigation is being organized. So it is a temporary measure to reduce intracranial pressure. A single episode of hypotension with a systolic blood pressure of less than 90 millimeters of mercury is associated with worst outcome in traumatic coma. Cerebral perfusion pressure should be maintained at more than 65 millimeters of mercury in severely head injury patient. So this is very important because in severely head injury patient, you may be asked the cerebral blood pressure or cerebral perfusion pressure appropriately at what level should be maintained. So it is more than 65 millimeters of mercury. We have seen earlier that how to calculate cerebral perfusion pressure. That is, cerebral perfusion pressure is equal to mean arterial pressure minus intracranial pressure. So if intracranial pressure is 20 millimeters of mercury, it follows that mean arterial pressure should be more than 85 millimeters of mercury to maintain cerebral perfusion pressure of 65 and above. So you can maintain intracranial pressure you can vary intracranial pressure by various means. A normal intracranial pressure is around 8 to 12 millimeters of mercury. A sustained intracranial pressure of more than 20 millimeters of mercury is associated with poor outcome. So how to maintain intracranial pressure? So you have to sedate the patient. So it will reduce the intrathoracic pressure and it will reduce the intracranial pressure respectively. So you can sedate patient with or without muscle relaxant. You can use diuretics. Judicial use of diuretics such as furosemide and mannitol will temporarily reduce cerebral swelling and intracranial pressure. So agents which can reduce intracranial pressure are furosemide and mannitol. Thermoregulation. This is an important part. Pyrexia will increase the brain metabolic rate and it should be avoided. Active cooling should be used to reduce metabolic rate as is of questionable but overall benefit is used sometimes. So active cooling can be tried in patients where you can suspect to have raised intracranial pressure. Next, you can make use of barbiturates. The use of agents such as thiopentone reduces brain metabolic rate and it helps to reduce intracranial pressure. But barbiturates are associated with respiratory and metabolic complications and can take very much days to clear from the body. The dosage is guided by burst suppression on electroencephalogram monitoring. So barbiturates should be used, but they should be used with very caution. Apart from maintaining good oxygenation, you have to maintain good fluid and electrolyte balance. Severely brain injured patients are susceptible to the disturbances of sodium homeostasis such as diabetes insipidus and syndrome of inappropriate antidiuretic hormone, that is SIADH. So if you are asked which of the following electrolyte abnormalities are common, so they are sodium abnormalities due to diabetes insipidus and SIADH. Next, you can control the seizures. The seizures increase the brain metabolic rate and should be controlled. They may also cause secondary events due to hypoxia. So prophylactic anticonvulsants may reduce seizures in the first week. So having seen various intracranial lesions such as hematomas, now we'll see various skull fractures. So what are the indications for repair of skull fractures? So elevation of significantly depressed fragments should be an indication for repairing skull fractures. Wound debridement for compound fractures, particularly if there is evidence of underlying dural injury such as contusion or CSF leak, may form an important indication of this fracture elevation. So if you find dural leak along with CSF leak, you should repair all these fractures. Many times base skull fractures are associated with 7th or 8th cranial palsies. CSF otorrhea or rhinorrhea often may resolve spontaneously. Antibiotics are not required prophylactically unless for concomitant facial fractures. So these all sentences are very much important because you may be asked question, in case of base skull fractures, which of the following is not true? So all these concepts should be made very much clear. A delayed craniotomy and anterior fossa dural repair is occasionally required for persistent CSF leak to prevent meningitis. So if you have got prolonged CSF leak in anterior cranial fossa fracture, you may require dural repair by exogenous material. Now we'll see what are the long-term sequelae of head injury. In this we have got neurorehabilitation, which will include medical nursing, physiotherapy and speech and occupational therapy teams. Next we have got neuropsychology. So post-concussional symptoms will include headache, dizziness, impaired short-term memory and concentration, easy fatigability, emotional disinhibition and depression. So all these group of symptoms constitute post-concussional symptoms. Next we can have seizures with long-term epilepsy affecting less than 5% of patients admitted with head injury. But the use of prophylactic anticonvulsants does not seem to change the long-term incidence of epilepsy. So long-term use of anti-epileptic should be made only in indicated patients. Next we can have delayed CSF leak. So patients with delayed or ongoing CSF leak should be investigated with CT cysternography or CSF isotope studies prior to surgical repair. Friends, having seen various Glasgow coma scales, now we have got Glasgow outcome score. So it is called as GOS. So please go through this scale very carefully. So you have good recovery at Glasgow outcome scale of 5, then moderate disability at 4, then severe disability at grade 3, persistent vegetative state at 2 and death at 1. So all these have impact on outcome. So we'll see what is meant by various outcome scores. So Glasgow outcome score and good recovery, that is of 5, it does not mean that there is no deficit, but implies independent functioning and possibility of returning to work. So there is mild disability, but patient is able to function independently and he is possible to resume his work. Patient with Glasgow outcome score of 4, they remain independent though with a disabling deficit. Patient with severe disability are called as Glasgow outcome score of 3 and they are dependent on others for at least some of their care. So most of the head injury patients form in Glasgow outcome score of 3. Patients in vegetative state are called as Glasgow outcome score of 2. They show no awareness of themselves on their environment. So they are lying continuously in vegetative state. So this state is not considered permanent unless at least 1 year after traumatic brain injury. So whenever patients have passed 1 year of their traumatic brain injury, then only this vegetative state or Glasgow outcome score of 2 applies. Friends, we have seen various head injuries like subdural hematomas, extradural hematomas, subarachnoid hemorrhage, intracerebral contusion, diffuse axonal injury, and various methods to manage them. We have seen difference between acute and chronic subdural hematoma, how their treatment differs. We have seen what is meant for post head injury intra neurosurgical care management. We have seen various rehabilitation measures that to be taken in post head injury sequelae. Thank you.